What does it mean to be a voice of change in the field of obstetrics? More specifically, what does it take to bring about this change? I'm Dr. Namrita George, an independently practicing obstetrician from Chennai, whose journey in the field of maternal health began about 12 years ago when I was a young intern. My path in the field of obstetrics, like for many others, was crossed with various hurdles and challenges. Right through it all, the only lesson that I managed to gather from it was that it was time for a change. To be able to understand why change is necessary, one must be able to understand the path that has led to it. So, I'm going to be giving you a little glimpse of my journey so you will understand how I navigated this road that's not often taken. 12 years ago, I had just finished my medical training and had been granted the privilege of doing my internship at a public maternity hospital. Now, let me give you a quick mental image of this space. The labor rooms, like in most other public hospitals, were always crowded and overflowing. Due to a lack of beds, laboring women would lie on the floors, sometimes alone, with no birth partner or family member to accompany them. Interns like myself would be running around collecting blood samples, connecting fetal monitors, checking vital parameters, and making frantic calls to the pediatrician, while postgraduate residents were alternating between vaginal deliveries and cesareans, spending the rest of their limited time writing notes. Not one of us would have known any of these patients by their names. It was always by bed numbers. Nurses would be holding mothers down while doctors conducted their births. Delayed cord clamping had not caught on by then. And once the baby was born and the sutures were complete, our next task would be to shift the mums out and bring onto the stirrups the next patient in waiting. There was really no time to rejoice or glorify birth. In fact, there's no time to glorify anything in the field of medicine. That's how scientific progress is made. At least that's what we've all been told. I knew right then, despite all of this, that I wanted to specialize in obstetrics. The only difference was I wished for it to be an evidence based, mother centric practice where the mission statement would be to address not only safety but also ensure that every mother's voice is heard and needs addressed to the best of our capacity. Fast forward a few years, and I was now a postgraduate in OBGYN. At this juncture, I must mention that during my period of training of MS obstetrics and gynecology, I had never, and I repeat, never conducted a non medicalized birth. I too was trained, just like my fellow colleagues and those for generations before us, in standardized obstetric care. Standardized obstetric care, where enemas were then mandatory, perineal shaving was compulsory, birthing in lithotomy position was an unwritten rule, and routine episiotomies was the norm. I do stand guilty of having encouraged these practices. I believed that I was following the right obstetric practice that was set in a particular format over years, and I hadn't really developed the mindset to question these practices. It was now the year 2015. In June that year, an article was published written by Sohini Sattopadhyay. It was titled The Horrific Sights and Sounds from the Labor Room of an Indian Public Hospital. The author had brought to light a very well known but unspoken pressing issue, which was obstetric violence. This article left me wondering. It made me realize how primitive some of our birth practices were, and what concerned me most was how somehow I had unknowingly become part of this system. This thought led to literature searches, which then revealed to me how labor management across first world countries was slowly changing, and how the demand for respectful maternity care was bringing about a revolution of sorts. It was sometime around then that I learned of midwives and obstetricians in and outside the country who were now tackling these small but multiple challenges which existed in the system. The theoretical knowledge of changing birth practices in various international guidelines helped reassure me, but I couldn't really understand where I was going to pick up on the practicalities of the same. How could I even think of comparing first world practices to ours? And would this mean that those at an economic disadvantage would never be able to dream of such a care? Luckily enough, life led me to a tribal hospital in a rural district within the state, possibly to answer these questions that I had in my mind, and also to understand how obstetrics works in rural India. I will never forget my first day there. The senior obstetrician who just retired showed me around the place. It was nothing like I had ever seen before. And I had occasionally visited some of the fanciest hospitals in the city side. The labor room was large and well ventilated. The floors were sparkling clean and the delivery room was well equipped. There was a mother in labor who was being assisted by the nurses and accompanied by her husband and sister, both of whom were there, reassuring her and assisting her. The obstetrician then asked me to sit and observe and not disturb this peaceful environment. It was later explained to me that the indigenous people considered medical intervention unnecessary for birth. They believed it was a physiological process and did not understand why the government was leading them towards institutionalized births. It's important for me to highlight at this point that this particular district had been infamous for its high maternal mortality rates when compared to the state average. When an inquiry was done, it was said by the officials that most of the people from the indigenous community would run away from public hospitals in an attempt to birth peacefully within the comfort of their homes, thereby leading to postpartum hemorrhage being the most common cause of maternal mortality in the district. In order to arrive at a solution for the high maternal mortality rate, this particular hospital had now set up a labor room that would resemble a tribal home to encourage families to bring their laboring mothers to an environment that was familiar, birth in private, in the presence of their partners, without unnecessary medical intervention, provided they were low risk. And all of this was going to happen within a hospital campus, which would now facilitate safe and respectful birthing. An idea like this is still alien to most hospitals in the city. In my time at this hospital, I had to unlearn a few of my city based practices, and my experiences there taught me everything that I practice till date. It was now time to return to the city, the new city I was now in, which was Bangalore. Already had a movement that had been begun by mothers for mothers. I started the practice of low intervention birth in a small nursing home, and thereafter began to see how this mother led movement had led to a nuclear chain reaction, turning many mothers away from hospitalized, medicalized births towards low intervention birthing. Over a short period of time, I have been fortunate enough to meet um, and carry forward the birth of a number of wonderful mothers, each with their own ideology of birthing. Mothers I see in the clinic today send me detailed birth plans or birth wishes, as they like to call them. They have queries on Lamaze classes and hypnobirthing and Ayurvedic practices, acupressure, water birth, and so on. On one hand, I am gladdened by the fact that mothers now spend a good amount of their time researching about pregnancy and understanding their bodies. But on the other hand, one just cannot ignore the gross inequalities in the healthcare system that exist. At this juncture, I'm going to state not mine but WHO's recommendation, where it highlights the importance of woman-centered care to optimize women's experiences of labor and childbirth through a holistic human rights-based approach, which includes the provision of respectful maternity care that maintains women's dignity, privacy, and confidentiality, enables informed choice and continuous support through labor and childbirth, and ensures freedom from mistreatment. The same guideline goes on to make other recommendations, including avoiding routine amniotomy, encouraging oral fluid and food intake, mobility in labor, presence of a companion of choice, encouragement of manual techniques like massage for pain relief, and many more. When I think of all this, I often wonder if those mothers at the hospital that I had once interned in would have ever gotten a chance to understand what all this means. And if you ask me why some of our archaic practices are still in place, as an obstetrician, I can give you plentiful excuses. But there's one reason that's really glaring right at our faces, and that's the doctor patient ratio in our country. The numbers are clear, and obviously, it's not possible for obstetricians to personally monitor by bedside the labor of all women. That is why, in a purely hospitalized setting, mothers are often left unaccompanied by their family, denied oral intake and the right to freedom of mobility, strapped onto fetal monitors for hours because a blanket safety rule is applied across to all mothers, low and high risk together, since a 1:1 monitoring by obstetricians is not feasible when there are large numbers. This, we understand, is not the case with mothers who choose alternate institutions for birthing, as they are monitored individually by midwives and sometimes assisted by doulas in the presence of a birth partner, which helps these women feel like they are in a safe and respected environment. Now, the concern here is that these institutions often cater only to low risk mothers, thereby resulting in a large number of Indian mothers having to head to hospitalized settings and left feeling like they are being denied the right to have a positive birthing experience. So, how can we bring about a change? You see, all birth workers know that low intervention birthing is safe for low risk mothers. However, experienced birth workers also know that in case of a complication, immediate medical assistance could go a long way in saving lives. This is exactly why I believe in the practice of collaborative care. Mothers are categorized into low and high risk, thereby allowing us obstetricians to focus on high risk mothers while continuing to serve as safety nets for low risk ones. In our OB practice in Chennai, low risk mothers are often encouraged to birth without any additional medical intervention, and there have been no significant differences in maternal or neonatal morbidity when compared to other low risk mothers who have had routine interventions. These mothers also often claim to have had better birth experiences. However, due to the lack of midwifery in our state, it is imperative that our obstetricians double up as the primary labor support and provide 1:1 care for every single mother in labor. In a period of about just over a year, we have been able to train our labor nurses into understanding what safe and respectful care is and have been able to bring about a change in labor management that has led to satisfactory results. The challenge we face here, however, is that a trained obstetrician is having to dedicate all his or her time to mothers in labor, irrespective of their risk status, something that could easily be overcome with the help of trained professional midwives. Here, I would like to quote one particular well renowned senior colleague who once said, having a highly trained obstetrician to attend a low risk birth is like asking a pediatric surgeon to babysit a 2-year old. It's not a self sustaining model, especially in a country with a population like ours. And this is why there is an uneven distribution of trained specialists in rural and urban areas. And this is also the cause of the current medicalization of births. Having said this, I would like to reiterate what I mentioned earlier. There is a movement, a movement that has been started by mothers that is spreading across states. And the sooner the collaborative care model is introduced in all hospitals, the better our maternal and neonatal outcomes will be. We must understand that despite the few differences that we may have as birth workers, midwives and obstetricians share a common goal: physically, mentally, and emotionally healthy mothers and babies. And we must learn to work on our similarities to help achieve this. If safe, respectful, and evidence based maternity care is your goal, then let your voice be the voice of change.